Good evening, good afternoon, and good morning. I am going to introduce the next session to you. It is Technical Advances in Therapy. The first speaker is Professor Soo Lee from South Korea. He is a specialist in nuclear medicine, in neurology and cardiology and molecular imaging and nanomedicine. He is the president-elect of the World Federation of Nuclear Medicine and Biology. He is also the past president of the Korean Society for Nanomedicine, past president of the Korean Society of Nuclear Medicine, and the past president of the Korean Society of Human Brain Mapping. His topic for discussion is radiolabeled ESION as PET MRI agent. ESION is extremely small iron oxide nanoparticles. The next speaker is Mariela Agolti. Mariela is the medical director of the Center of Nuclear Medicine in Rio, Argentina. She is also the current secretary for WAMP. Her topic for discussion is advance in image guidance of radionuclide therapy using fluorine-18 PSMA. The last speaker for the session is Professor Mike Sathekge from South Africa. He is professor and head of department of the Nuclear Medicine Center in the University of Pretoria and Steve Biko Academic Hospital. He is also the president of the College of Medicine of South Africa, the national specialist examining body for all medical disciplines. He is also the president-elect for WAMP. His topic for discussion is setting up new radionuclide therapy units, do's and don'ts in alpha therapy. Thank you so much for joining us, and I trust that these sessions will be highly informative to you.
So, good day, everyone. I'm very happy to join this virtual ICRT conference 2020 in Bangladesh, Dhaka. And my talk is about an example of radio-nanomedicine. Radio-nanomedicine is a combined nuclear and nanomedicine. And the concrete example of the cutting-edge research regarding radiolabeled extremely small iron oxide nanoparticle as PET MRI agent is going to be detailed by my colleague, Professor Soo. So my talk will consist of the introduction, and which will last 5 minutes. So the promises of nanomedicine has been introduced recently by ourselves and other colleagues, and the radio-nanomedicine's advantage lies in the feasible tracer kinetic. Why? We have labeled nanoparticles or nanomaterials with radionuclide. So the PET and SPECT or other imaging machines can be used to trace and can quantify the kinetic of those materials. And also, because we have used the radionuclide to trace, so those kinetics, we can reduce the amount of nanoparticles to be administered to the human body to the trace amount. So these two characteristics are seminal or essential or most important for theranostic use of those nanoparticles, which had been the concern of the experts and also the public for their possible the toxicity or the lasting effect of those pharmacologic dose. So, which means that in case of the MRI imaging, we used to use gram unit of the gadolinium agent, which can cause systemic the problems in some cases. However, when we use the radionuclide, we use the trace amount, which is microgram. So at least no pharmacologic effect is expected. Then we ask the questions. What about the tracing capability of those the radionuclide labeled nanoparticles? So in this case, we usually use the 0.05 picomole for tracing the radio-labeled nanoparticles, but we increased by just mixing cold form of nanoparticles. So we did the same, the tracer kinetic studies with imaging here. We could not find any difference as is in the textbook for a long time in nuclear medicine, and also which was also cited in a radio nanomedicine literatures, including our the book. So the nanoparticle can be now tamed. So we further proceeded to find out how we can just make the nanoparticles to target the organs and tissues and tumors. So I can just raise that if there are some difference in the surface characteristics, then the subtle differences on the surface can make the specificity. However, it should have been documented. So my colleague a while ago, in addition to the passive targeting capability of those nanoparticles, he just modified the surface in a very subtle way, just hydroxyl residue of this glycosidic the structure was just to change it from galactose to mannose, and we found that there is a real difference, and galactose is targeting hepatocyte and mannose is targeting the copper cells in the liver. So it moved on to the most recent the investigation using the galactose or the mannose labeled albumin. In the meantime, we have adopted the every cutting edge technology, including the click labeling method, and the same albumin molecule has been labeled with fluorescence dye and also radionuclide, and which was injected to the animal, and after intravenous injection and PET imaging was acquired, which revealed, as is expected, galactose was taken up by the gallbladder and then excreted to the intestine, and mannose was taken up by the macrophages of the MPS, or previously reticuloendothelial cell system, and RES. And then after sacrifice of those animals, ex vivo fluorescence microscopy was done. And as you have seen here, as is expected also, the galactose labeled albumins were taken up by the hepatocytes, and finally they were excreted to the intestine, and then mannose labeled ones were taken up by the copper cells, as well as the sinusoidal epithelial cells of the liver. So here I listed among those many nanoparticles which were suggested by our colleague, the material engineers, and also nanotechnologists and chemists and chemical engineers. And among those many, our group have been involved in using those materials like quantum dot and upconversion nanoparticles, source dot. However, I'm going to emphasize that we might use the iron oxide instead of the other inorganic nanoparticles. Why? Because iron oxide had been used for MRI imaging already. And so if I just kind of blow up the difference of the size of those nanoparticles, the iron oxide can be 5 nanometer diameter, whose size is less the smaller than the albumin. And as I just told you, surface can be modified for targeting, and biodistribution and physiology can be monitored using PET and MRI. And using trace amount of material and using the tracer kinetic method, which is well established. And those kind of advantage had become the basis of our new book, published 2 years ago. So this is before entering into the real presentation regarding PET MRI agent and using ESION. This is a kind of diversion. The key to the physiologic visualization of a newly found CSF lymphatic drainage in the humans and also mammals, including rodents. Here, the adjusting volume, not administering too much amount of the exogenous materials into CSF is a key, and also the concentration is also the problem. And so that kind of problem can be solved using the radionuclide labeled nanomaterials, in this case the albumin. And that's the Dr. Asmar, who is now working, studying in my institution, has recently acquired when he just injected successfully to the intrathecally the CSF space of the mouse. And the copper-64 labeled albumin was drained via lymphatics from the CSF, which was discovered only 5 years ago, which was in the paper published in Nature. And this kind of RI cystosonography type of imaging had been already in clinical use for several decades, so you might be quite expert. And this kind of success can be expanded to every field of nuclear medicine or theranostics. So this is quite a end of the introduction, and let me just invite Dr. Seo.
Hello, I am Min-Seok Soo, research professor from Seoul National University Medical Research Center. I am very honored to have an opportunity to share our experience in this ICRT meeting. Today, I would like to share our experience of application of radionanomedicine for extremely small size iron oxide nanoparticle, the ESION. As you can see, there is a decreasing interest in the field of nanomedicine. And what might be the reason? The most important reason is that there are scarce of nanoparticles that have passed through the clinical approval and used in the market. And still, there are limited nanoparticles which is readily on the clinical trial or have acquired approval. So there are several challenges that we encounter during the process of clinical application of nanomedicine. So we should have a technique for scale-up production, mass production, and we should be aware of pharmacology such as pharmacokinetics and dynamics or effectiveness. And lastly, we should confirm safety issues and pass through the regulatory issues. So I would like to share how the development process of micelle encapsulated ESION as T1 contrast imaging agent and how we have dealt with such challenges. So before starting, what was the unmet clinical need is that actually gadolinium is the most widely used MRI contrast agent worldwide. However, evidence of nephrogenic systemic fibrosis and identification of tissue deposition, such as in brain, has raised concerns about its use recently. And based on these reports, Korean FDA have actually halted the supply of some gadolinium contrast agents. So there has been a need for a new MRI contrast agent which may have less safety and regulatory issues. What we have chosen was the iron oxide nanoparticle. And this iron oxide nanoparticle is a biocompatible nanoparticle which has a long history of clinical application. And from decades, only minimal toxicity has been reported over time. Moreover, this gadolinium is an extracellular agent which spreads to the extracellular space immediately after injection. And they are rapidly removed by the kidney, so the blood pool half-life is actually short within like minutes. So as a result, there is a limit for intensive high-resolution imaging, which require long time of image acquisition. Compared to that, because of its sufficient size, iron oxide nanoparticle can function as a blood pool agent. And also, iron oxide nanoparticle has been used clinically as a T2 contrast agent. However, this T2 agent is actually a negative contrast agent and has inherent limitation. So it may cause susceptibility artifacts, and T2 image itself also takes a long time for processing. So for these reasons, iron oxide nanoparticle-based T2 contrast agents are no longer in use. So the development of next generation contrast agent with safety and characteristics of T1 contrast agent is required. Thanks to Professor Taekwon Hyun from Seoul National University, recently, they developed an iron oxide nanoparticle with a core size less than 5 nanometer. And at this size range, iron oxide nanoparticles can show a property of T1 contrast agent. So this agent was named as extremely small size iron oxide nanoparticle, which is ESION. And as you can see from the image that ESION have longer, compared to the gadolinium-based agent, it has a longer blood pool activity. To further apply this ESION in the clinic, the mass production is necessary. And again, Professor Hyun previously proposed a thermal decomposition method for nanoparticle production, and this method enables mass production of nanoparticles in a stable and size-controlled manner. However, since this method uses organic solvent in the process, hydrophilization is required for further application in vivo. So Lee and Zhang from our group have proposed an encapsulation method using micelle for hydrophilization. So this micelle encapsulation method have advantage as it can provide a mass production, cheap production, and also easy production of nanoparticles. So now we have a prepared, relatively biocompatible agent with mass production method. However, in order to apply this clinically, it is necessary to understand the dynamics of micelle encapsulated ESIONs in vivo. There are several methods which can be used for quantifying and tracking iron oxide nanoparticles. So ICP-MS is the gold standard method to quantify the iron concentration. However, since it is an ex vivo-based tool, it cannot be used to differentiate endogenous iron in living animal. And Prussian blue or iron assay tests all have advantages since they are rapid and affordable. But like ICP-MS, they are also ex vivo-based method and cannot be used in the live animals. So there comes a imaging-based techniques. And firstly, optical imaging is relatively affordable tool. However, this optical imaging has its inherent limitations, such as weak tissue penetration. And there can be a quenching from the iron oxide itself, which limits the accurate quantification of the iron oxide nanoparticles. So we have another tool, which is the magnetic particle spectroscopy. And it has an advantage as it is not interfered by the background or endogenous iron. However, this technique can only be applied to iron oxide nanoparticle, which limits its versatile application. So this is where radio nanomedicine comes in. And as you hear from Professor Lee, radiolabeling has revealed to have no dose dependence, and as it uses trace amount, it can be an ideal method to demonstrate the in vivo biodistribution and pharmacokinetics of micelle encapsulated ESIONs. And in addition, simultaneous PET MRI, which was built in our institute, have provided information for direct comparison of PET and MRI signals. So now we have prepared a radio-labeled ESION. This radio-labeling process consists of 3 steps. First, we prepare the monodispersed nanocrystal and the micelle. We then encapsulate these ESIONs using the micelle. And lastly, we labeled copper-64 on the surface of the micelle. And as you can see, the characterization, both the pre and the post radio-labeled micelle encapsulated ESIONs reveal that there was no significant change in size or relaxivity after the radio-labeling process. And using this radio-labeled ESIONs, we observed the biodistribution and pharmacokinetics. And as you can see from the image, at the earlier time point, the radio tracers were mainly visualized along the blood pool. And from 4 hours, liver and intestines are seen, and most of the activities are retained only in the liver at 72 hours. So compared with other agents, this radio-labeled ESIONs showed relatively long blood circulation time, which is approximately 60 minutes. And also compared to the other agents, this radio-labeled ESION showed rapid clearance through hepatobiliary system. And to check the stability in vivo, we collected the stool sample and evaluated the radiochemical purity. And as expected, it showed that radio-labeling of copper-64 is well retained, and intact form of copper-64 labeled ESIONs are cleared through the hepatobiliary system, which shows that this radioactivity of copper-64 actually well reflects the in vivo dynamics of micelle encapsulated ESIONs. So we used this radio nanomedicine to reveal the pharmacokinetics of ESIONs. And in summary, this radio-labeled micelle encapsulated ESIONs showed relatively long blood circulation time and rapid clearance through hepatobiliary system, which emphasized that this micelle encapsulated ESION is an effective T1 contrast agent. However, there are some additional points that should be discussed, that we have previously applied this micelle encapsulation technique to upconversion nanoparticle. And similar to this study, micelle encapsulated this UCMP also shown rapid clearance through hepatobiliary tract in a similar rate. And it is actually reported that micelle encapsulation of ESIONs may lower the recognition by the RES, which in the liver is Cooper cell, and can be effectively internalized into the hepatocyte and excreted through the hepatobiliary system. However, the exact mechanism should be enlightened in the following study. So consequently, this micelle encapsulation technique is expected to be able to improve the excretion through the hepatobiliary tract, regardless of the type of what core particle we use. And as we use simultaneous PET MRI, we conducted a direct comparison of PET and MRI signal. Generally, in the high concentration range, due to high T2-related effect, signal quenching is observed. And radio-labeled ESIONs showed a similar pattern in our experience of non-linearity and reduce of T1 signal intensity in the high concentration range. So as seen in the image, you can recognize that MRI signal at 5 minutes and 1 hour is relatively similar, whereas the PET signal has significantly reduced after an hour. And this, through having high tissue resolution, such non-linearity of MRI signal again emphasize the strength of radio nanomedicine for tracing nanoparticles. And interestingly, in the liver, MRI signal quenching was observed over time, as you can see from the image, while the radioactivity remained relatively constant over time. Since the liver is the organ where most nanoparticles accumulate or pass through, these radio-labeled ESIONs have been accumulated in the liver RES Cooper cell or in the hepatocyte and endothelial cells. So we checked from the liver washout model that signal quenching of this MRI is proportional to the retention fraction, and we could have concluded that a signal quenching in the liver is actually relevant to the cell internalization. And this actually is not a new finding. It is known that MRI signal can be affected by the local distribution of the contrast agent. And the signal quenching may occur when the local distribution of contrast agents change from freely dispersed to cluster state, like the situation as cell internalization. So furthermore, from the image, you can see that using this, using the relaxivity, we can also check the freely dispersed and cell internalization fraction. So this quenching effect after cell internalization can limit the accurate quantification. However, using this, various clinical application may be possible. So this work from 2015 has proposed a strategy to image tumor necrosis from the speculation that administered iron oxide nanoparticle may be freely dispersed in the tumor necrosis and while internalized and clustered in tumor tissue so that it can differentiate the tumor necrosis to the tumor tissues. So as you can see, the MRI can reflect cell internalization fraction, and PET can provide a quantitative value of total concentration of the region of our interest. And so combining both, this radio-labeled ESIONs can reflect the microscopic distribution. And this, if we can know the microscopic distribution, it can further be applied for monitoring tumor microenvironment to discriminate such like cold tumors and hot tumors. So for summary, we have used this radio nanomedicine to trace the micelle encapsulated ESION, and we have seen that radio labeling process doesn't make a change in the characteristics, and this radioactivity of copper-64 has well reflected the in vivo dynamics of the ESIONs. And finally, micelle encapsulated ESIONs showed relatively long blood circulation time and rapid clearance through hepatobiliary system. So, micelle encapsulated ESION is an effective T1 contrast agent, which is revealed with the aid of radio nanomedicine. And furthermore, direct comparison of PET and MRI signal revealed that signal quenching in the liver is relevant to cell internalization. So further application of this radio-labeled ESION can be used for monitoring microscopic distribution. So thank you very much. This is end of my presentation.
Hello, good afternoon. Thank you for this great opportunity of sharing our experience in 18-fluor PSMA PET-CT in prostate cancer. My talk will be about indications, difference with other radioisotopes, normal distribution, biochemical relapse in local nodes and distance, and differential diagnosis. I have nothing to disclose regards this talk. The indications of gallium-68 PSMA PET-CT, according to the procedure guideline stated by EANM and SNMMI, are localization of tumor tissue in biochemical recurrence, and biochemical recurrence is especially recommended in values in low PSA values between 0.2 and 10 nanograms per milliliter. It is also indicated in primary staging in high-risk disease before surgical procedures or when planning external beam radiation. High-risk disease is when you have a Gleason score more than 7 or PSA value are more than 20 nanograms per milliliter at the beginning of the disease. But there are also emerging clinical applications. One is staging before and during PSMA-directed radiotherapy with lutetium-177, they are theragnosis part, targeted biopsy after previous negative biopsy in patients with high suspicion of prostate cancer, and monitoring of Sathekge treatment in metastatic prostate cancers. There is an standardized reporting guidelines produced by the European proposal that is to score your finding between 1 to 5. 1 is a benign lesion without abnormal PSMA uptake, and being 5, a definite evidence of prostate cancer with intense uptake in a typical site of prostate cancer metastasis. Regards the pelvic nose nomenclature, we have to remember that from common iliac vessels down, that is in the pelvic lymph nodes, it will change the end stage. While if you have lymph nodes above this level, they will change the M phase of the staging. I really like and recommend to use this PROMISE report system to report PSMA PET-CT. Regards local tumor, they divided the prostate almost like in MRI, and you, according to this, you can say your patient is local T21, T22, T3 when it goes out of the prostate, and T4 when it is more outside the prostate. But the most important thing here is regards regional nodes and distant metastases. Regards regional nodes, when you have one node or you have oligometastatic disease, like in this case, but when you have lymph node outside the pelvis, it is M1A. And if you have those metastases in liver or in lungs, it is M1C disease. Regards bone metastases, that are the more commonly seen metastases in prostate cancer, you can have only one lesion, you can have 3 lesions, this is oligometastatic disease. You have disseminated metastatic bone disease, and you can have disseminated but with bone marrow involved. The detection sensibility of this methodology varies according to PSA levels. Between 0.2 and less than 0.5 nanograms per milliliter, we had a very high sensibility, almost 62% according to different works. This, with the previous tracers like choline, was almost 35%. And between 1 and 2 nanograms per milliliters, we have a very high sensitivity in diagnosis. These are the tracers that are available to diagnose prostate cancer. We have 18-fluorocholine. It is very similar to 11-carbon-choline PET-CT, and you can see here the normal distribution. The choline has a problem, that is the low sensibility for low values of PSA. On the other side, you have 18-fluorofluoxycarbine, which is quite good. However, this cannot be used as a diagnostic pair with lutetium or actinium because it is not chelated. So the ideal radio tracers, I must say, can be gallium-68 PSMA, 18-fluor PSMA. There are differences between these two. One is the cost, the other is the half-life. 18-fluor PSMA has a longer half-life, and that allows you to bring it from another nuclear medicine department in case you don't have a generator. And also a very important thing, that is the urinary excretion of gallium-68. You can see here the urinary excretion and no urinary excretion with 18-fluor PSMA. This allows a better diagnosis in the local relapse. Here you have both tracers for diagnosis pair with lutetium or actinium and gallium-68 PSMA with urinary excretion and 18-fluor PSMA, no urinary excretion, and it helps the diagnosis of local relapse. Regards biochemical recurrence, we defined it when the PSA level is more than 0.2 nanograms per milliliter. And it can change the management in 29% of the patients when the lesions are located in either regional lymph nodes or bone. After external beam radiation therapy, 2 nanograms per milliliter or more above the nadir after 6 weeks after therapy completion is required to diagnose biochemical recurrence. This is one of our patients. It is 75 years old, radical prostatectomy 10 years ago, and we have increased in PSA level 6.5, 8.8 nanograms per milliliters, in April 9 nanograms per milliliters. And he underwent this 18-fluor PSMA PET-CT. You can see in the local place a relapse in the prostate bed. This patient had underwent a choline study some weeks before, and it was negative for a local relapse. And here we can see in our MIP that we have a clear local relapse. Once more, local relapse in these patients. Regards node disease, this is another patient, 75 years old, post-radiotherapy. The nadim was 1.08 nanograms per milliliters, PSA actual 4.45, and you can see in the MIP increased uptake in pelvic lymph nodes, like here. This is our patient undergoing 18-fluor PSMA PET-CT, and you can see a small lymph nodes here, which were the responsible for the rise in PSA. If you see these lymph nodes, they are very small to be seen in normal CT. So undoubtedly, in this kind of patients, PET-CT is very good. There is another one, small lymph node here. This is another patient with 80 years old, radical prostatectomy in 2011, a stable disease until 2017, and then PSA started rising and was controlled with anti-androgen therapy. Again, in 2019, PSA rises, and you can see here in the MIP multiple lymph nodes, hypermetabolic lymph nodes, that are consistent with release with active disease in these lymph nodes. You can see this patient also underwent choline PET-CT with increased uptake, but in very little lymph nodes. However, when we do PSMA PET-CT, we have a lot of more lymph nodes increased uptake. And one more thing, you have here a normal size lymph node with no uptake in choline and with increased uptake in PSMA. So this proves once more that PSMA sensibility is much higher than choline sensibility. Regards bones and liver metastases, you can see here one patient with multiple increased uptake in bones. This patient had a rising PSA value, and there is this very interesting article on bone metastasis done by the people from Innsbruck, and you can see according to the tag pattern, there is a difference, an important difference in SUV max in PSMA PET-CT. This was done with gallium-68. However, I think we can extrapolate these results. In osteolytic lesions, we have the most higher SUV value. In sclerotic lesion, it is sometimes it is no uptake. And when it is not non-visualized in CT, you can see moderate increased uptake. This is the patient I showed you previously, the MIP. You can see a sclerotic lesion with fine uptake. Here there is sclerotic lesion with high uptake. And here we can see a lytic lesion with increased uptake. So you have to be aware of the tag pattern and the uptake in these patients. As I promised, I am showing you a list of benign pathologies mimicking prostate cancers. You can have it in granulomatosis disease, such as sarcoidosis, tuberculosis, benign bone pathologies like Paget disease, fibrous dysplasia, healing bone fracture, hemangiomas, benign soft tissue lesions, adenomas, and cerebral infarction. It is very common to see this pitfall when reporting PSMA PET-CT that we can find increased uptake in celiac ganglia. In these cases, you have to take into consideration the SUV, that is clearly more higher in patients with metastases, and the uptake pattern, when it is linear than focal and low grade than high grade, and also the anatomic appearance like adrenal gland or coma shape, they are more commonly seen in normal variants. Regards malignant PSMA-avid pathologies other than prostate cancer, there is a number of cases reporting this. We have it in follicular lymphoma, multiple myeloma, papillary and follicular thyroid cancer, pancreatic neuroendocrine tumor, gastrointestinal stromal tumor, squamous cell carcinoma of the oropharynx, many cancers, colorectal carcinoma, hepatocellular carcinoma, lung cancer, we had a case of this, breast cancer, glioblastoma, and meningioma. You have to be aware of this finding in these patients. A very new article I want to share with you is this that was published this year, is that the PET-CT helps defining the best treatment in metastatic castration-resistant prostate cancer. How? If you have a patient with this situation, you can think he's progressing, you have to make your patient a dual tracer PET-CT, a gallium-68 and 18-fluor FDG PET-CT. Also, you have to take into consideration the Gleason score. If the PSMA is positive and the FDG is positive with high grade of FDG uptake and a high Gleason score, probably your patient will have a better response to taxane-based chemotherapy, docetaxel, cabazitaxel. But if your patient is PSMA positive but a low grade of FDG uptake with a low Gleason score, it probably would be better to use a combination therapy lutetium PSMA, PRLT, and abiraterone. So really, in this time, 18 PSMA, fluor PSMA PET-CT is helping us to make better decisions with our patients. In conclusion, we already know there is a superior accuracy of PSMA PET over conventional imaging for staging in high-risk patients. How? Because it may allow identification of patients with occult distant metastatic disease, and this can change the treatment in many, many patients, almost 29% of them. Now there is a large volume of literature demonstrating that the very high sensitivity of PSMA PET-CT regards the other conventional imaging, especially in patients with low PSA levels. Regards 18-fluor PSMA and other radioisotopes to do prostate cancer, we know that 18-fluor PSMA demonstrates high leveling yields, better tumor uptake, non-urinary background clearance compared to gallium-68. It can be produced in larger amounts and it has a longer half-life with a higher physical spatial resolution. This allows you, if you don't have a gallium generator in your own center, you can bring 18-fluor PSMA from other places and use it in your patients. Also, 18-fluor PSMA can be used for theragnosis because it includes a chelator capable of binding therapeutic nuclides, lutetium-177 or actinium-225. Thank you very much for your attention and looking forward to meet in person all my friends from WOM.
Good morning and good evening to all people of the world and friends of WOM. It's exciting to be part and parcel of this ICRT, especially with the manner in which it is organized, probably the first of its kind to be organized this way, and one is thankful to the organizers and the innovation that is shown here by the WOM organizers. Really appreciate it. To all the people, starting from the president, the executive, to the executives such as Josh here and Anthony, really appreciate it. So speaking about alpha therapies today, it's going to be something that is interesting. We know alpha therapies are really something that we are looking forward to because they are showing great promise, but they really have got problems. They can really cause toxicities, and therefore we've got to be clear about knowing what we are doing and be clear about what should happen. So we have to have authorized facility to really deal and handle alpha therapies. We've got to really treat the correct patients. We've got to plan properly and make sure that the planning is really going to achieve the results and understand what are the consequences of alpha therapy for the disease and for the patient in terms of side effects. Of course, our aim is that we should improve the management of the patient. And then I will also demonstrate some clinical experience that exists in terms of the alpha therapies that we know here. Alpha therapies, why alpha therapies? They are essential in terms of addressing the reoxygenation that we find within the carcinogenesis and angiogenesis. Therefore, really, that the metastases that are there, it can address that. The repair that is there, leading to resistance to cell death, they can attach and really speak to that. Repopulation that is there that leads again to resistance and invasion of growth suppressors. Again, the alpha therapy seems to be helpful in that particular instance, and radiosensitivity is an important thing. And then, of course, lastly, redistribution that is there, all of them leading to resistance to cell death. And hence, the comparison between beta and alpha therapy is essential, but alpha therapy basically has got this 5 hallmarks with regards to management of cancer. Demonstrating the difference between the two, as you can see, really we're speaking basically about comparing something that has got a particle mass of 7,000 to 1. The comparison is very, very huge, as you can see clearly here as well. I mean, the linear energy that is transferred, I mean, 0.1 to 60 or 1 to 300, that's really big. Therefore, you need small hits, 1 to 4 compared to more than 1,000, with in favor of alpha. Therefore, it makes it a bit irreparable or difficult for the cells to repair themselves compared to actually a beta emitter. And hence, that's why they are showing great potential of showing what we can do. In terms of how the space they travel, as you can see, a beta emitter will really traverse a longer distance compared to an alpha emitter, which will be confined mainly within the tumor, because the path that it travels is very short. And therefore, really, we can impart that big energy, sparing the surrounding normal tissue. And theoretically, we should therefore have limited side effects in that regard. Some of the cancers that have been treated with alpha and beta therapies, I will speak about several alphas, but specifically and more importantly, the radium and actinium are the ones that are commonly used. Some of the examples of usages by actinium and bismuth therapies, both of which are alphas, and one will not go in again into the really how they decay in details, but safe to say that both of them are this bismuth is a daughter of actinium, really coming with alpha of CD6, and this with alpha of 10 days. It can be treated, it can be used in leukemia, lymphoma, melanoma, bladder cancer, gliomas, neuroendocrine tumors, but importantly in prostate cancer. In this last two, the last three, there has been good results, but in the others, perhaps not so much good results, but it is coming there. And then it is something that really we should look out for, because as you can see, this can be a problem in especially leukemia, but that will be difficult to handle, of course. So showing you some examples before I'll explain what are the precautions we should do using prostate cancer. With the fewer and with the rarer applications, one will not go into the details of what to do and what not to do, but just to show that in glioma therapy, this has been utilized, and you can see the team in Poland are demonstrating this, where you can actually impart bismuth labeled to a substance P. Therefore, it will actually go and destroy the lesions that could not be operated. And they have demonstrated good results in terms of what the outcome are in patients that would have had a very short survival span, and they've demonstrated increased survival of those patients, and that's commendable. Another example is that of neuroendocrine tumors. I think this might actually show good potential to grow. Yes, I mean, lutetium dotatate, it's really applied globally and it's working well, but there could be place for where there is resistance. We could actually use the targeted alpha therapy labeled to actinium. In my center, we've also utilized it in some of the patients. I mean, this is the work again from Heidelberg and Poland utilized, showing that actinium can be labeled to this, and you can see the results are really there, showing that indeed you can have this. It's very promising, but there is limited data about this, but really it's something to watch out for, that actinium label to dotatate. It's something we should look out for. Once actually, when it was done, Intracavitate 3 won the Society of Nuclear Medicine Image of the Year award, showing that it is really indeed promising. In hematological malignancies, not much of it has really come into routine usage, as you can imagine, because obviously it's systemic and it's within the blood, but actually actinium lintozumab has shown some result that we should watch out for. In these patients of leukemia, we should really see what the results are, and then there are really things to watch for to say that really we could start to see how could we utilize it in prior to cell transplantation and other targeting strategies. But of course, it's as you can see in these images, there is a long way to go, but Dr. Jurus has actually demonstrated good work, and we're looking forward to see what will happen in that space. Alpha therapies are also utilizing something that may help in bladder cancer. This is again a place where I definitely think it would probably pick up utilizing bismuth 200, the 46 minutes half-life alpha therapy that is there, actually putting it intravesical, the catheter, and then of course it will obviously then within the bladder be there interspersed, and of course irradiating locally, and therefore then removing it again. And this is the results, as you can see in the mice. And then in human studies, limited studies that have been there, again, it is actually showing very great results. My apologies for not showing the author of this Dr. Soo Lee from Munich. That's very good work that they are doing there. So now stepping out of those other therapies and going to other prostate cancer, which is where really I think alpha therapy have actually reinvoked its time again and really come to be really alive. So in optimizing PSMA therapies, we know that lutetium PSA, which is PSMA, which has been spoken by colleagues and friends in other lectures, it's really successful, it's working well. But of course, again, there might be some shortcomings. And when that comes, what do we do? How do we optimize PSMA theranostics? There are various ways of optimizing. It is by selecting the patient well, making sure that the imaging is done well. I'll touch briefly on it. But it's not the subject of today. And then you can utilize ligands, changing the PSMA to be bigger. You can use radiosensitizers such as PARP, and then of course, but today you can use other isotopes. Instead of using lutetium PSMA, you can change an isotope from a beta emitter to an alpha emitter. So you can optimize it in that way. And that's the subject of today. So in this way, again, showing the strength of beta versus alpha, that of course clearly the beta will really have less energy, but it's very good results that we are utilizing, and this is routinely done. Of course, this is really in very few centers at the moment that we are doing it. Of course, we have to express the positive targets before we can treat. That's very important, before we can treat with of course the actinium labeled or even bismuth labeled PSMA. So you must see it before you can treat it, and that's important. And of course, the mode of action, before we speak about how we select the patient and the precautions, it's essential, like with neuroendocrine tumors and others, wherein we are just going to have a mere injection, and that injection will go in concentrate. Of course, the radiopeptide will be there, it's binding to the sites, and then it will be internalized. And then upon internalizing, it will deliver the energy to the cells and clearly break the DNA. In the case of an alpha, then we are theoretically thinking that it breaks both strands of the DNA compared to the single strand by a beta emitter. So if you are going to embark on an alpha therapy, what should happen? Let's start with the facility and the personnel requirement. It's important that, the facility must be licensed as per national regulations that you can handle alpha emitter. So make sure you apply for that, and then you must be sure that you are authorized to receive it, store it, and transfer it, and also the disposal part of it. Ensure that you do have the correct radiation safety equipment. One will not speak to the details so long as it's enumerated here, what is needed. The colleagues can look into the finer details, and there is work that is there in the Seminars of Nuclear Medicine of March 2019, as well as in the work of Skouros, which is published in the Nature journal. So the SOP on handling and disposal of waste is important, and the contamination should be handled, and the monitoring and of personnel, it's again critical. You must have the correct equipment and the SOP thereof. And then there must be authorized personnel that are dealing with this, the medical physicists, the radiographers, and the MDs within the department that are really qualified to deal with this. The personnel should realize that they will not start without really speaking to the other referring doctors. This is a multidisciplinary team. The personnel that are really handling this, they've got to be knowledgeable about the local registrations and regulations of handling alpha emitter isotopes. They've got to understand the pathophysiology and natural history of the disease, whether we are dealing with prostate cancer, neuroendocrine, or bladder cancer. You've got to know what you are dealing with and what you anticipate that will be the response to this. You must be familiar with other forms of therapy, so that if you know your alpha and then how your alpha decays and the kinetics, you might say, in this particular instance, I don't think the alpha therapy will work. You might want to refer for this type of therapy. So that knowledge is important, or you might want to know how that knowledge might end up interacting and really causing problems for your therapies. So the disease profile as well, its pathophysiology and the form of therapy are important. You obviously have to be clear that you are going to be responsible for treating, for aftercare, and for follow-up. It's not like somebody referring a patient for a scan to you, you scan and then you are finished with them. When you treat with this alpha therapies, those are your patients. As if you are seriously an oncologist or a cardiologist, you are a treating doctor. And really, yes, you will also liaise with the referring physicians, but you are responsible for those patients. And of course, the risk factors are there. You've got to know what are the target organs for each type of therapy you are doing. For instance, for radium, you might want to worry about the bowel. If you've got inflammatory bowel diseases, you might want to actually consider that and treat with the referring physicians. Of course, for actinium, PSMA specifically, salivary glands can be a bit of a problem. So those limiting organs have to be very clear what is happening and which are the other ones that are there. For instance, is the kidney going to be a problem? And then how do you manage it? You must try, just like all the principles of radionuclide therapies, if you've got a person that has got imminent spinal cord compression, try and make sure that that is handled so that you don't end up with a problem before you resume the therapy. Just like with the fractures, make sure that they are stabilized. Usually it will take around 10 weeks before you can resume the therapies. Avoid treating and working, especially with the alphas as well, when there are those spinal cord compressions or fractures. You've got to be aware of the cumulative radiation exposure that you're going to give to the patients. Yes, it is important, and theoretically, as one has said, there's very short path that is traveled by actinium, radium, and so on, but you still can cause other cancers if you've got accumulated radiation. And we've got to realize that we should avoid myelodysplastic syndromes, leukemias that can end up being incurred by a patient. And therefore, working as a team with the medical physicist is also very important in this kind of patients. So how do we select these patients? Just like we do with lutetium, it's an interdisciplinary process. We've got to make sure that the patient is showing progression of disease from things like surgery, radiation therapy, importantly, hormonal therapy, and of course, they must be having some life expectancy. It's around 5 months. They mustn't be having an ECOG of 3, otherwise don't touch those patients. And then, of course, they must have a positive scan. The blood results and the lab parameters are important. You gotta make sure that their hemoglobin is okay. Some would even say around 8. And then, of course, the platelets and the white blood cells that are within the normal limits. Do a scan to rule out, a renal scan to rule out obstruction, because otherwise it's going to be a problem if they're obstructed. And the GFR has to be within the normal limits together with the urea and creatinine for the patients so that the excretion is not going to be impeded. You must be having histological proof of what we are treating and demonstrated that the testosterone demonstrates that it is castrate resistance for those patients. And you must in many of the guidelines demonstrate that you must be demonstrating that they are post-ADT before you start them, and they have refused chemotherapy or are not fit to be treated with chemotherapy before you start. The patient information and instructions are crucial. You cannot start without having a consent form, of course. The consent form must be really informative. It must be spoken to, and there must be written information as well, written and verbal, before you start. And it must be clear that when you are treating it, there are going to be various cycles, say 2 to 6 cycles, but it's for the entire cycle that we are really concerning, entire schedule that you are concerning the patient. But be aware that if there are going to be deviations and the patient is going to be sick with something else, you might seek a new consent form. If there is a change from how it started, you might want to cover that and be clear that you might want to have a new consent. In a consent form, I think we also, as we are treating, we have to be clear that we tell patients we will not cure them, but we are going to control the disease or hopefully get them into remission. And then that's an important thing that we are telling them, that we are aiming to prolong the survival and improve the quality of life. I don't think we can at the moment speak of cure, and that's very important. We've got to be very upright and forward about the side effects and telling them what are the side effects and that are clear so that they know if they want to withdraw, they can withdraw at the stage. We've got to tell them what will happen to their household members, caregivers, and the public so that they can avoid and look after them. Not so much of a big problem with alphas as it could be with beta emitters, but nonetheless, as they go into the washroom and the toilet and so on, those issues have to be addressed clearly with them, and written instructions are important in that regard. And then those patients must have a card in case they're going to travel or in case they've got a medical emergency, so that every person can know what they have received. This is just an example of how you select them using imaging, as one has said before, but other people, before they include this patient, they use FDG as well, because if there's FDG concordance, it means the patients are likely to succeed well. The same as we do for lutetium, it is the same for actinium. But if there's disconcordance, as you can see clearly in this particular instance, FDG expressing more than actinium, then you have a problem. And similarly, if there is very little of PSMA compared to FDG, you don't treat those patients. But if PSMA is more or concordant, then you do treat. But be cautious that, especially if you're going to re-challenge, that you can treat a patient that were having concordance, but later on when you re-challenge, there might be a discordant wherein the FDG is now more. Again, you might not want to treat those patients. And you might also want to try and see that when you select those patients, that your PSMA scan is at least above the liver. The lesions are intense above the liver, so you know that it's going to be good. Or if you want to semi-quantify, looking at the value of about 15 SUV, but some people are not using that value because it depends from one equipment to the other. So in terms of preparing the patient, then it's important that the patient are well hydrated. It's very, very critical. You may want to adjust it in cardiovascular patients. And if they are having incontinence, please put the catheter to avoid catheterization. Even if the patient wants to advise you otherwise, do convince them it's important that they do have the catheter in that instance. So essentially speaking, there are no pre-medication that are required with actinium PSMA, for instance. But in some patients, you may want to give corticosteroids, especially those that are demonstrating diffuse liver metastasis or diffuse bone metastasis. Something like prednisone 20 milligram for 2 weeks might actually do them well. And then, of course, usually these patients with actinium, lutetium, and so on, they may have nausea and vomiting. You might want to have antiemetic drugs such as aldosterone or metoclopramide to help with the nausea and vomiting. Salivary glands is a bit of a problem. It's a side effect of actinium PSMA. There are patients that are, especially in Europe, that gives ice for cooling. It's controversial because you really have to give ice to really damage the skin, probably to stop the circulation there. And there are things like Botox that are not effective or dangerous if you don't know how to do it well. But I'll revert back to it when I show the example. Treatment protocol, it's essential in this particular instance that it's basically an IV bolus. Within a minute, the treatment is done. But remember the hydration again, before and after, that is important. Before you treat, it's important that you must flush before and flush after, even if the line has been going, just so that you know that there isn't going to be an extravasation. Because if extravasation is going to happen, especially with an alpha emitter, you do have a problem. So whether the drip is running or not, have a 3-way stopcock. It's really highly recommended. You flush before, you are sure that it really doesn't, the cells are still fine. And then, of course, push your actinium. Then after that, again, push your saline to make sure that it's really pushed in and it cannot come back. When you do that, try and put an absorbent and water or water impermeable material just in case there's a spillage below to protect the skin and the surface around, so that it's not a problem. And as I've said, the incontinent, the catheter, it's a must under such patients. So you have to also realize that the patients are really gonna be dependent on how heavy they are really with their disease. You may give cycles between 2, 3, 4, 5, but usually maximum of 6. And that really it's important to realize that, patients differ, but you probably, it's not advisable to do anything after 6. You might want to give a patient a break if they're not responding, or discussing an MDT, of course. And then in terms of actinium, anything between 6 to 8 weeks, but currently most of the centers globally, we're giving it after 8 weeks because of the limited supply of actinium, more than the scientific reasoning behind it. And then, of course, as we treat patients, in terms of examples, the tumor sink effect is important to demonstrate that really at the beginning, you may give a higher dose because obviously there is negative correlation between the tumor load and the PSMA. So the higher the tumor, the more the non-target tissues will receive the dose. So your kidneys and salivary glands will receive less, but as the tumor gets less, then they will receive more. So that's why you can actually end up having a justification of dynamic de-escalation as we are practicing, starting with a higher dose and going down. So you can see here in this particular instance with the tumor all over the skeleton, if we gave a higher dose, salivary glands are spared, but as soon as the tumor is less in the skeleton, then you'll reduce it and then try to spare the non-target tissue such as the salivary glands. In terms of following them up, you will follow them up with the examinations and the bloods. Not all the time it's possible to clinically examine them, but then with an MDT and other colleagues, if they are staying remote, make sure that the bloods are there and then you know what is happening. And then after a month, you can then do your tumor marker and see what is happening to the patients. And clearly it's important again that really when you do image, you may image after the third, fourth cycle. It depends on, again, the financial toxicity and the skin, but at least you must have the baseline scan and then at least at the end. Some centers may image after every second month, during each cycle. Of course, radiation has to be taken into cognizance as well. So that really is variable a bit, but you definitely need your baseline, obviously for inclusion, but also for when you are going to say the patient is stable or remission or progressing. Of course, as a warmth community, we have to show our study, a very excellent one, even if it's on beta emitter lutetium PSMA, it still speaks a little bit to what I'm discussing today, alphas, because this study essentially says that if a patient have had chemotherapy before, they've got an ECOG 2, and then they've got liver metastasis, and they've got extensive bone metastasis, they are likely to have a shorter overall survival. The same with actinium, when they have had chemo, ECOG that is not 0 or 1, or liver metastasis or bone, they also express a shortened overall survival. I think this study is a very important one. So what it means is that when you have this type of things, perhaps maybe might have to think about what you give in terms of the regimen, the dosing. Are you going to give higher dose or so? That's an interesting phenomenon that again needs to be discussed. And then with the alpha, as one has said, really one is demonstrating again that this is a very good alpha actinium to give for prostate. In the past, we gave bismuth in our center in the first in human one, but it's very with a short half-life, it doesn't work well. And hence, really actinium is really a great one, and especially in diffuse and extensive metastasis. And of course, that's, as I've said before, how you select them. We have happened to have treated with alpha several patients from superscan-like severe, moderate, soft tissues and minimal diseases because they didn't have any therapy that could be given to them. But of course, as soon as it's below the liver, that's caution mark, and one should not actually try and go there. But you can see here, and of course, why. You may say, why did we give alpha on limited disease like this? But as you can see, for instance, in the schema below that, in fact, an alpha emitter, it will internalize and really it will give the highest radiation to the lesion and very little to a marrow. So it theoretically actually can give it to patients that are small, especially if you can solve the issue of salivary gland toxicities in this particular instance. But at the moment, it is more advocated for severe and superscan type of patients. Yes, again, one will not go into the decay model of what it does and the dosimetry because of the time factors, but just to say that based on the work that was done on Heidelberg territories, it has really shown that really having 100 gigabecquerel per kilogram is actually the ideal, and that informed us why we could start with a dose of 8. You would actually have limited side effects, but yet you would, as you can see, limited side effects, but very effective for the therapy. But as you go higher, you start to have side effects with your non-target tissues. Of course, you will target the therapy as well. And then as you go lower, again, you're starting to be not so effective in your therapies. So really that balance was well designed, and the dosimetry around this is commendable. But then you can de-escalate after that. The literature which was published by the group in India recently has demonstrated very good effect, and independently from various groups, from the Heidelberg group, from our group, and from Munich, and then from the Indian group as well, demonstrating clearly that you will have a PSA fall of more than 50, which is commendable, above the 60s. We have demonstrated even higher, but these are in patients that didn't receive chemotherapy, which is something I think futuristically we should think about together with the oncologist, of really the sequencing of what should happen. Interesting, yes, controversial at the moment, but it's something to bear in mind of the role of alpha therapies in that regard. And just to demonstrate that with this optimization of the sequencing, these two studies separate from or two publications. The Heidelberg group got a patient that is 5 years post actinium PSMA. So you can see didn't have much disease, but the patient really even today demonstrates that there is no recurrence. We have the patient as well, several of them. This is one of them, 3 years post, and some of them just 2 times actinium PSMA that are still under that. So what does that speak to the sequence? Because all the situations were chemo naive, of course, for various reasons. It could be that the patient was not fit or the patient refused chemo. But nonetheless, it demonstrates clearly that alpha could play a role in that situation for the long-term survival of these patients. This is just one other example of a well-tolerated, effective modality that shows you with a super scan that really becomes normal, and yet sparing the bloods. As you can see, the platelets, hemoglobin, and the kidneys are really doing well. And of course, the patient still in remission. And you can see, really technically speaking, you would have thought this patient was going to do bad. As I have shown from that one study, the more bone metastasis, that lessened the overall survival, but this patient so far is doing well. Showing that beta emitter, when it fails, even 10 times getting lutetium PSMA, you can resolve to giving alpha therapy, and it may work. But of course, that study, that type of phenomenon of what you do, is still ongoing, so that there could be a situation of using them one after the other or starting theoretically with lutetium. But at least this anecdotal work does demonstrate that you can give lutetium and follow up with actinium. And then it's not going to be contraindicated in patients with single kidney. Beta work with lutetium demonstrate you can treat with single kidney, and we are showing in actinium in alpha that still you can. It's not an exclusion factor to have single kidney and get therapies. You can see the GFR remains more or less the same whilst the lesions are gone. And of course, what about the most side effects for this therapy? Trying to rush to finish, we can see that xerostomia can be a problem, but as I started in the beginning by saying we can optimize by playing with the ligand. You can see if you're making the ligand bigger, which is the work of Christine Muller, is demonstrating that if it's bigger, then it will actually go less to the salivary glands, but staying more in the blood, and therefore the tumor will get the benefit. That might be another way of actually working in this. And this may also show favorable dosimetry, looking 617 versus this new IBUDAP PSMA, which is albumin bound. You can see the dosimetry seems favorable. We really look forward to seeing what will happen. Alternatively, you can do a combination protocol wherein you're giving lutetium and actinium together. This work shows that the combination hopefully might spare the salivary glands. So there's various ways. We are using mainly the de-escalation, but we also have access to IBUDAP from the work of Christina Müller. So those two approaches might be working, whilst the Heidelberg is using the tandem supply. Chemotherapy, as one has said in that one study and the other studies, it's a problem. And we are saying that if we can resolve by having a molecule that will go less to the salivary glands, perhaps we can also start targeting the chemo-naive patients. And therefore, that might be an interesting discussion for the sequencing of this type of patients using alpha therapy. Another type of alpha therapy that one must briefly discuss, and that is actually also helped to open, is radium-223. Radium, it's a bone-seeking radionuclide. There are several radionuclide therapies such as strontium, samarium, Chandra was the more known. But out of the calcium analogs, Radiolabeled has been the one that has made a big breakthrough and really has made a lot of input for nuclear medicine as well. Again, I'll not discuss the decay schema part of it, half-life of 11 days, but it is convenient because it is a bone-seeking and therefore very potent as well for DNA damaging. Like actinium, it will also obviously break the double strand of it. The sequencing part of it, of course, it is 6 cycles that are given clearly, and it's very well established. Like we have said before, the bloods have to be normal. And you might want to also add ALP and LDH strongly in this particular instance. And then after every month, you then repeat the cycle, and so it goes. And this as well has been done by the group of Elba in Brazil, that you can actually give it in asymptomatic. Don't have to, so long as you've demonstrated metastasis, you don't have to wait for a patient to be symptomatic. You might want to give it earlier or mildly symptomatic rather than waiting for when they really are having big metastasis. And that's interesting to know that they are demonstrating again what are the overall survival of this important work. Really decent work that shows clearly again from various authors that shows really the results of survival being good, and that indeed that's something to really watch out and include in our arsenal. You could actually want to look at it in combination with PSMA as well, because remember, radium goes purely to the bone, and then what about the soft tissues there? And therefore the combination might be interesting. And I think the former president of OMT, Irene Bergolin, was actually advocating for that. You can see clearly here we do have the work of Homer Mackenplank showing clearly that you do have, as I have said, I think in one of the slides, that you might have your clearance, but fecal clearance might be there, and then you might want to worry about the bowel in that instances. But otherwise, there is no significant organ redistribution. You can see that because it's an alpha, the imaging is not like the pure MDP that you would see. There is a long retention in the bone, however. And then this famous work by Parker et al. Has demonstrated that median overall survival of 14.9 months, which is important, and hence radium has really made inroads, and it's important. So of course, this work in concluding colleagues shows as well that in higher bone lesions, you might also have that as something that will compromise your survival. So again, what does it speak to the sequencing if it is like that, obviously, and that's something to speak about. So in conclusion, targeted alpha therapy, it's rapidly growing, and really we have to pay attention to that. It's really going to be a serious contention to really deal with, because it is rapidly growing. There are reasons for that, and those reasons are that really travels a short range of time, therefore sparing the normal tissue. It has got a high linear energy transfer, therefore killing the double strand of the DNA. And then of course, we should select our patients well. We should have the facilities that are really well equipped, personnel that is really well versed with the therapy. But we should, of course, plan well, understand and evaluate the consequences of alpha therapies. Definitely, we will demonstrate the good lifespan for those patients increased, and then that is tumor shrinkage. Thank you.